Yes. Thank you, Ben, for organizing the meeting. And thank you, all the Chicago HIP team, for having me here. So we talk a little bit about persistent pain following hip arthroscopy in the borderline dysplastic hip. Shall we go straight to BAO? My disclosures can be found in this QR code. So today we know that the BAO is a treatment of choice in patients with hip dysplasia, and we have shown excellent outcomes at long term. These patients are able to go back to normal life and being really active. However, when we talk about the borderline hip, it's actually a lot of controversy. Some proponents of doing the BAO in these patients, and then some others that said with hip arthroscopy, you should be okay. So as we have seen this morning, decision-making is actually a clinical dilemma. So what happens when you treat according to the literature? What happens when you treat with hip arthroscopy a borderline dysplastic hip? It has been shown to be successful at short-term follow-up. However, 40% of these patients may still experience a suboptimal early outcome. And most studies report high variable degrees of success when doing hip arthroscopy plus capsule application. So this is a study systematic review where they reported the amount of failures that you see if you treat with hip arthroscopy a borderline dysplastic hip. And the problem here is that it's very variable. So you will have studies that they basically do not report any failure, and then you will have studies that they go up to almost 50%. So when you start reading these papers, the problem is that they're only reporting on the LCE. So we are not really comparing the same type of population or patients, although we are all calling them borderline dysplastic hips. So if you look into the literature, what is the most common procedure that patients get after a failed hip arthroscopy in the borderline dysplastic hip is going to be another hip arthroscopy. This is a study coming from this group here, from Ben, and they did a study where they compare doing revision hip arthroscopy in patients with borderline dysplastic hip and patients with non-borderline dysplastic hip. And they reported like the PROs improve with time. But when you look into the MCID, definitely that borderline dysplastic hip group is not going to have or to get the same amount of MCID high as control group. And they even report the fail in this doing a revision hip arthroscopy. 18% fail, were treated with another hip arthroscopy, and 22% were converted to total hip replacement. So the authors concluded that arthroscopic revision surgery in the borderline dysplastic hip should be approached with measured prognosis. What if you do a PAO after a failed hip arthroscopy? So this is coming from our group at OSU. Basically, in this study, you can see we have 156 patients. And from this group, there was a subgroup of patients that have had a previous hip arthroscopy. The interesting thing that you see here is that if you do a borderline dysplastic hip like Jeff showed this morning, we have excellent clinical outcomes. And if you have a patient with a previous history of a failed hip arthroscopy, they will improve, but they will never do as well as a primary PAO. So we believe that we definitely support the PAO as a second procedure, but we do believe, and our data shows, that the patients do better with a primary PAO. And this is another study coming from the ARMCOR group, kind of showing the same things. The patients that have had a failure hip arthroscopy improve, but they will never do as well as a primary PAO. So again, we support PAO as a second procedure, and patients do better with a primary PAO. So what do we do in clinical practice? So we believe that the borderline dysplastic hip in the setting of a failed hip arthroscopy does better with a straight to PAO approach. When patient presents with a failed hip scope, instability must be ruled out, and we believe that it's unstable or loose until proven otherwise. And one of the most important things that we have been talking this morning is that we cannot define instability or loose hip or borderline hip just only using the LCE. So this is what we do in the setting of a previous failed hip scope. we are going to go through patient characteristics. It's not the same having a female dancer loose, rather a rock climber or a soccer player. So these are different type of things. You have to think about the patient, Baton score, etc. In the physical exam, we definitely look at the range of motion, especially prone, just to have a better idea of the femoral version. Ask the patient if they have had a psoas tendinitis, any injection into a psoas sheath. And then X-rays, we do not only look at the LCE, but we look all other parameters such as the tonus, the posterior wall or anterior wall index, and the fear index, as we discussed this morning, I think is very important. And then, of course, all these patients are going to get a 3D imaging modality. So in regards to stability, what the things that we ask the patient normally is, do you have lateral hip pain? That's very common of instability. These patients will present with lateral hip pain at the end of the day, just because they have abductor insufficiency. So that's actually, most of the patients will say that. Of the patient, if she or he feels loose, it's very common that they'll say, yeah, it kind of feels like the hip is trying to come out. History of psoas tendinitis. Have you had any injections in the psoas? Have you had anybody done a release on your psoas? And then I do a lot of hip diagnostic injections because a lot of these patients come with kind of pain everywhere. So it's very important that, because they kind of patients like chronic pain, they come with a failed hip scope for a year or two. So these patients are going to have pain in the side joint, lateral, back, etc. So it's very important to do diagnostic injections. We use CT with contemporary digital mapping systems, and I'll show you a little bit later. And then we always going to repeat an MRI, correct? We want to see the anchors, we want to see chondrosis, subchondral cysts, etc., capsula. So this is a case of mine. She's a 23-year-old female, competitive cross-country runner. She came in my clinic with history of 2 years of hip pain. So at that point, we knew that she had failed non-operative treatments. You see here, the X-ray is classic borderline dysplastic hip with an LC of 21, tonus 1, so not really terrible, and then an ACE of 18. In the physical exam, classic borderline hip with good range of motion, fatty and favor positive suggesting rim disease. That does not mean that the patient has a torn labrum. And then again, range of motion 90 degrees of flexion, IR of 15, and IR prone of 40. When we did the MRI, there was a torn labrum, so probably decided that she would probably need a hip arthroscopy. And her femoral version was 22, so not really something that will raise my attention and say probably she's very unstable. So since she was a runner, we initially decided to do a hip arthroscopy alone. Runners are kind of the athletes that is hard from them to get back to full level of activity after a BAO. So I think it was reasonable to try to get a hip scope and see how she does. When we did the hip scope, there are a couple of things that made you think that this patient is unstable. So she had a very pristine joint, small labrum tear. The destruction was very easy. And then, of course, we did capsular closure. But this patient persisted with pain at 1 year following the surgery. We tried a couple of hip steroid injections just to calm her back and see she was going to get back to the mileage she wanted to run. And she wasn't able to run competitive. So we did additional hip mapping. And we basically, one of the things that I look a lot into these patients is the femoral head coverage. We have published on that. And the dysplastic hips normally, or unstable hips, they normally have femoral head coverage under 50. So this patient definitely had very low femoral head coverage. So we ended up doing a PAO, and she got back competing at 1 year, and today she's 3 years and she's still competing. And this is another case, 17-year-old dancer. So that's something that made you think this patient may be loose, more unstable. History of right hip pain for 2 years, so she has failed non-operative treatments. And again, the classic numbers, LCE of 22, borderline hip, tonus 2, ACE a little bit undercover anteriorly, range of motion, excellent range of motion. The MRI did not show much, so that's another thing that you think this must be instability. We did the hip mapping, femoral version of 26, so nothing terrible. Femoral head coverage 53, so that's what we normally see in borderline hips. Normally they are between 48 to 55. So for me, that femoral head coverage is borderline dysplasia for sure. Wouldn't be really concerned about too much instability with a 53, but definitely I will never see a 53 in an FAI. So when we decided for her to do hip scope PAO just because of the patient characteristic, dancer, loose patient. The mapping was kind of showing that. And that's kind of what we see when you use the Guardian table. The traction table, like only applying 50 pounds, you can get that amount of distraction. So that's another thing you can use in the OR, like see how much, you can count the amount of pounds you have to put. So with 50 pounds, it's actually very low. Normally for a patient with FAI cam, non-dysplastic or non-unstable, you will normally be between 75 kind of pounds up to 100 to get it distracted. So these are, we did a PAO, and 1 year following surgery, she went back to dancing. I'm happy. So in conclusion, when dealing with a patient who has a failed hip scope in the setting of borderline dysplasia, instability should be the first factor to be ruled out. Decision-making factors should not only consider LCE, but associated patient characteristic, physical exam, X-rays, 3D imaging modalities. And although the hip scope continues to be the most commonly repeated procedure following a failed hip arthroscopy, we believe that proceeding directly to PAO provides a more predictable outcome. Thank you very much.